This topic, children's palliative care, is extremely close to all of us at Novi Survat Goa. We work with our heart and soul in order to help those in distress, especially children with chronic illnesses in the state of Goa. So before I begin, I would like to know if you all know what is palliative care. Okay, what is palliative care, ma'am? Okay, terminal illnesses, okay, what else? Okay, anything else? Okay, palliative care is not only for the dying, okay? Palliative care is for anyone when the diagnosis is detected. Maybe it may be as early as childhood or as late as it's not as early, it's not as late as, meaning not, it's as early as childhood, as late as adulthood as well. So it's the onset of the diagnosis that you're with the child, it's early integration of palliative care till the end, till the child dies, and even after that, because the family requires support, bereavement support, because grief is a long process, it does not end. You may think that the child is dying, so the family is grieving. Don't go with that thought that grieving will stop there. It will go on for years and years because a memory will trigger and the patient or the child or the family will go back in that same process. So palliative care comes from the Latin word palliare, which means to cloak, to cover. When I say cover, not with a blanket or with a bed sheet, it means to provide them holistic care. Cover them with your TLC, which is tender, loving care. So that is the meaning of palliative care. You are providing quality care for the whole family, for the whole child. It's not just the child, it's the whole family. That's why it is the whole, not the part. As psychologists, we know what is whole versus part. Same way, it is the whole that we cover when we're looking at the child and the family. So our main aim is to reaching out to patients and families with illnesses where there is no hope for cure. Okay, so we are reaching out to the whole family and the child where there is no hope for cure. And moreover, this concept is recently very new in Goa, okay, but it's been there for many years. And the founder of palliative care was Cicely Saunders. Okay, she actually started the hospice movement, followed by Dr. Mount, who's a surgical oncologist who coined the term palliative care, because there is a difference between palliative care and hospice care. However, they are interchangeably used, but hospice care is mostly for those who are terminally ill, and palliative care is early integration. However, there's another term which is called respite care, which is where you put the child for some time to give the family some rest. Okay. So what is palliative care? It's basically an approach that improves quality of life of a person and family who have no hope as their diseases are incurable. Okay? So we are looking at them so that we can be some ray of light for them, some form of comfort that we are there for them as palliative care providers, and also making sure that this family has somewhere to lean back on, because at the end they are always running between hospital, home, tube change, feeding tube changes, then some tracheostomy change, so they are all the time running in and out. So we are there to support them throughout this journey. So how do we do palliative care? Actually, in palliative care, our main aim is to provide psychosocial support. But also it is pain relief, symptom relief, psychosocial support, emotional support, spiritual support, because a lot of existential questions come in at the end for families. So who will give palliative care? Not anybody or not any counselor or psychologist can give palliative care. You need to be trained in this field in order to provide palliative care, and especially when you want to standardize quality of care. Not anybody can. Even after you all graduate as psychologists, don't one day go say that I'm a palliative care counselor. You cannot be. You need to be trained. Now you will ask me next question, where do I get trained? That also I will tell you where you can get yourself trained and how can you get that experience in being a palliative care counselor. So who gives palliative care? It's a whole team. So we are a team, multidisciplinary team at Novi Surbat, Goa. So we consist of a doctor, a nurse, a psychologist, a social worker. We have community volunteers. So right now we have just one community volunteer because not very many people are interested in going out of their comfort zone and helping out. So yes, we have this kind of community that we have adopted in Usgaon, where we look after this place. We conduct screening camps so that we can help out the children who are actually in need of or who need early detection and need palliative care support. So our aim over here is to provide holistic, complete care for the whole person. So when I say holistic, complete care, it's not only medical. We look at their psychological, emotional, look at their social aspects. We look at their financial, okay, if we can provide them with any financial relief for a temporary period till the family can regain its financial strength. We make sure we provide nutritional support, okay, to the families, so that the child does not go without food or without any nutritional supplements. We make sure that they get their medicines and they're compliant. So we make a regular follow-up of these patients, that they're giving their seizure drugs or any other medication that the child is on. We look at the community so that they're accepted around their, around their homes. Because we have come across families that address to us saying that, the neighbor's not allowing me to even keep my child outside, thinking that my child will infect the other children in the neighborhood. Now this child is a child with cerebral palsy. So you cannot expect a child with cerebral palsy infecting someone else. But this kind of thing happens in Goa, where they are not allowed to, sitting out and talking, even to their neighbors. They just treat them like untouchables. So when a palliative care team goes and visits these homes, they actually sensitize people around that, no, we are coming, so we are not getting infected. Why would you all get infected? So that kind of approach we have, where we are going in and actually sensitizing people about illnesses in children, and especially in their areas. So coming to the main question is, what is children's palliative care? It's the active total care of a child's body, mind, spirit, and also giving support to the family. Now you might wonder what a child feels. What does he understand about dying? What does he understand about his disease? Trust me, they understand everything. They understand the process of dying. They understand what they are going through. They may not know the crux of the disease. They may not understand the in-depth functioning of what is happening to them, but they know that they are ill. The very fact that the child is coming out from the hospital, going back to the hospital, knows that the child is ill. Also, he knows that he is dying. I'll share a nice experience that I personally had with a child with cancer. So his wish was to have a phone. And now we know that he is terminally ill. And we know that he's short time and he's going to go very soon. So this child says, Didi, aap mere ko phone la ke doge? So usually we don't give phones because we feel like, why do we spoil the child with a phone? It can do something else. And we have a recreational therapist on board who's with me today. She helps in actually giving therapy sessions to the kids in the homes. She goes to their homes. So I said, why you want a phone? He says, no, Didi, de do mujhe phone na, please. So discuss this in our meeting. Somehow we had a sponsor who was ready to give this phone. So we gave this phone to this child. Then we would do regular follow-ups with him at home. And when he did the follow-up, so I said, "Aap kya karoge is phone ka abhi?" "Nahi didi, pata hai kyun phone manga maine? Abhi main nahi rahunga to meri didi ka exam de sakta hai." So my didi can give the exam using the phone, because that time online classes were going on. So his idea was asking me a phone that when he is not there, she will use it. So the concept of death was already there. So he already knew that he was dying. And he did die peacefully in his gaon in Nagpur. So he didn't die in Goa. He went back home, died peacefully. Phone was his sister. And the bereavement process was so smooth after that, because it took us a while to actually make the family understand especially the mother. She was a single mother. So make her understand that he's going, and the process of weaning her through that whole thing. No doubt she still now thinks about her child, but she says, Didi, that experience that I had today, and for me to think that, my son is in a better place, and knowing that my child is now going to, this memory is there of this phone with my daughter, is beautiful, she says. So she keeps in touch with us. Now it's almost 2 years he's dead. the mother keeps in contact with us, tells us what is happening with the daughter, what's happening with her, and that's the process that what we look at. We look at actually giving quality death at the end. That's our whole thing. Our journey should be that, because we need, at the end, we come in dignity, we should also go in dignity. We shouldn't be left in a place that is unknown. And especially for parents who have children who are suffering, that, when we adults suffer, it's okay. We say like, oh, it was his time, or it was her time. She suffered so long. But a newborn or a child who's just 8 years old, who was fit and fine, suddenly now dying, it's quite of a task for them, or rather, it's a pain for them to even feel that my child is diagnosed with this, and now he's going or she's going. So it begins when the illness is diagnosed, as I said. So right now in Goa, we don't have early integration of palliative care. So sadly, we get referred when the child is extremely bad or severe. Okay, so we are working on early integration. Hopefully someday we reach that point where we get references from the day the child gets diagnosed. So we are right now in the process of making that happen for us and for the family, so that we are in the system when the child is diagnosed. So now sadly we get when the child is actually very serious. So otherwise, it begins when the illness is diagnosed, continues whether or not the child receives treatment directed at the disease, until death of the child and beyond that. Now it could be for years together we are in contact with the family. So our support does not end. It does not end with the death. It ends with the child as our patient, but it continues with the family till the family decides to leave us and doesn't require any support or any kind of counseling ahead from there. So who are these children that come to us? Okay, they are children aged 0 to 18 years of age, diagnosed with life-limiting and life-threatening illnesses. Now, can anybody tell me the difference between life-limiting and life-threatening besides the doctors? Life-threatening is when there is cure, but due to a relapse, the child is actually going down. The prognosis becomes poor. So for example, cancer. Some cancers got complete cure, some don't have. Okay, so when there is a relapse, that's the time you call it a life-threatening. And life-limiting is when there is no cure at all and the prognosis is fast. For example, Duchenne's muscular dystrophy, which is a disease of the muscles, okay, where the proteins, doctor would know it better, when the proteins are breaking down and the muscle actually starts to wear out. So there is an atrophy of the muscles that takes place. So that is Duchenne's muscular dystrophy. So like an example, I've given the child on a wheelchair. So when we look at this child in totality, we are looking at the child's physical, psychological, and social distress, and making sure that we can actually give effective measures to handle this. So we have children who become now a child with cerebral palsy. He cannot talk, he cannot hear, okay, everything is involved. His limbs are also completely involved, all 4 limbs. Now this child is in extreme pain. Now how would you understand this child is in pain? We cannot take the distress score, the pain scale we cannot ask the child, tell me which is this out of 5, which one are you, we cannot do that. So how would you know that this child is in pain?
Is the child verbal?
No, completely non-verbal. Oh yeah, mixed sounds, yes.
So he would be actually screaming his lungs out if he's in pain.
Okay.
Yes, we would get to the emotions of the facial expressions.
Okay. Anything else? Mobility is hampered. Yeah, it is hampered, meaning the child cannot walk, cerebral palsy is basically to do with the cerebellum, so the child's complete mobility. Change in behavior. How would you identify that change in behavior?
First was calmer, then usual behavior.
Screaming, yes. So many times when he asked, like for example, recently we have had a child referred from from PNRC, that is the Pediatric Neuro Rehab Center. Now this child was referred to us for counseling because when they went to the orthopedic surgeon, the doctor said that the child has dislocation of the hips and is in pain. Now the family thinks that because of his condition, he's crying all the time, so nothing new for us, he's just crying. But his crying intensity increases when you catch him. So the family did not realize this. For them, it is like, a regular thing. What happens when you're you're always in that same process of dealing with the child who's ill? You feel like, oh, this is regular, nothing new. Now for us, since we are trained in it, we were able to identify that this child is actually in distress because of the dislocation. Now our aim was to actually counsel the family in order to go and do the surgery. Now during this process of the counseling, we realized that the mother did not understand what the doctor told. For her, they were all jargons, and she was unable. So, it's doctor's duties to tell that, it may succeed, may not succeed. Always that is there. We have to tell, they have to tell. So the family first only got scared, like, oh, what if this happens? So the adversity. What if this happens? Now what am I going to do with my child? So we had to go in and explain to them that this is what we tell, what they tell, doctors tell you. But it does not mean that you do not go in and do the surgery. If you do not do the surgery, now this boy is a 15-year-old. He's always going to be in pain, firstly. Secondly, we are not going to be able to do physiotherapy for him. We may be able to do some good to him with the physiotherapy. He's not going to sit for RT classes. He's not going to do any form of any activities. If we plan for him some recreational activities, he's not going to do. Even if we try to teach him something, he's not going to do. So the parent had to understand that there is hope for this child if we do this. So the process of counseling becomes very important when it comes to children who are actually unable to tell. Okay, it's counseling the family, not the child, because the child will not understand what we are saying. So we have to tell the family that this is the problem in the child, therefore you have to do this. Only then will you be able to give some kind of help to this child. Because families think when diagnosed with something like this, child is pisso. That is the first thing they say. We go for home visits, are think pisso raut mare. What is pisso? We only have coined the term pisso. So that is it. So even if we try to tell the mother, feed the child with a spoon, he's playing with the food on the plate. Madam, वो दिमाग से गया है. इसको spoon में डाल के क्या होगा? So the whole thing of firstly educating the family becomes very important. And only when we can educate the family are we going to be able to understand the child's physical, psychological, and social. Because if we go directly to help the child, the family is not willing to do anything for the child. So our aim is first the family, then go to the child when it comes to counseling. Novi Survat is not the only organization that is wholly or solely going to care for this child. We work in collaboration with other organizations. For example, Childline. Heard of Childline? Yes. We work with Childline. Heard of Sabra Care? Anybody heard of Sabra Care? Yeah, we work with Sabra Care. Then we work with other organizations outside Goa. For example, in Tata's, we try to collaborate with Can Kids. Heard of Can Kids? Yes. Then we have Sanjeevani. So we used to work with Sanjeevani as well when collaborating, especially for counseling. So we are not the only organization that is going to take responsibility for the child when it comes to giving the best care, but we hold accountability for that child. Okay. So palliative care is not only provided by us, but also can be provided by tertiary care facilities, community health centers, palliative care units, and at a child's home. That's what NSG does. That's Novi Survat Goa. So children's palliative care team consists of we all. Okay. So we have child authorities. So who are the child authorities in Goa? So if you want to put a child in a rehab center, who would you go and contact first? CWC. Child Welfare Committee is the first where you present the case in front of CWC, and then depending on that, we have to place the child. But sadly, they don't take non-Goans. It's only Goans. Now, because of the shortage of space and all, they are only taking Goans in the rehab centers. So we present the case in front of CWC. CWC takes a decision depending on how the case is presented. Now, as an organization, we can present the case to CWC along with the family members. So do you know of rehab homes in Goa? Any rehab or any centers, homes for children? Yes, Matruchaya Ponda. Yes, Opium National. Sister orders, yes, then. El Shaddai. Asro, yes. Who said Asro? Okay, Asro. Peace Haven, yes. Okay, I don't know of it. In Shiolim. Anywhere, anything else? Yeah, Daddy's home doesn't take right now, I think. Yeah, it's special. It also comes under CWC. But I don't know whether they have now. What? No admissions, no, right now, till last not taking, they were shut. I don't know whether they have reopened. They were supposed to reopen this June. But I don't know whether they're having in-house. I know that they have a regular school for Down syndrome and other disabilities. Which one? Parshuram for boys with disabilities? Okay. Often. Anything else? Okay. Yes, cares. Not the schools, cares, yes. Do you all know of, just for my knowledge, I want to know, because I'm struggling to find a home for children with special needs. You know anything in Goa besides? Not yet. Yes, they take, but they don't take non-Goans, they take only Goans. So anything you know that will accept non-Goans? Huh? No, P7 also, ma'am. No, not yet. Nobody yet. So you all can always work on this. Little Angel Shara. But they don't take non-Goans, only Goans. I've been there, nice place. If you want to refer some child there, they really do good work with them. So we have child authorities that work with CPC team. We have other NGOs like I've mentioned, Sabricate, Childline. Then you have Pratik Menezes Memorial Foundation. Ever heard of this organization? Yeah? Doctor? Yes. Pratik Menezes Memorial Foundation was the first foundation to actually help children with cancer in the state of Goa. This is back in 1990s. And that's where I began running a project with them in 2018 in order to support children with cancer. Then Novi Surat came into existence. So they are the first organization, and they still continue to support these families, who are now the child is in remission. They support the child with meaning monthly follow-ups or yearly follow-ups, support the child with rations, with nutritional support, even treatments when the child was sent to Bombay. Right now they're not taking new cases. They are all follow-up cases, old ones. It's still in existence. Other schools, so we work with schools, especially special schools and regular schools in case the child is going to a regular school. So we try to coordinate our needs with the school, making sure that the child receives whatever help they require at school, making sure that they go for their special ed, they are taken in for special ed, and especially children with HIV, they do not, some schools are, the question of status comes in, so we try to not disclose the status, but make sure that the child receives the schooling that he deserves. Funders, so NSG or palliative care cannot work on its own, so we have a lot of funders that have to help in allowing this facility to, or this kind of cause to run. So we cannot work on our own. We need the support of locals in Goa, outside Goa, to actually help us run this kind of system. Family doctor, so we always make sure that when we are working with this child or this family, we make sure there's a family doctor in place. So that if there is no family doctor, then we try to contact the nearest PHC, that's your primary healthcare center, so that we can do some kind of help for emergency. Or the family doctor will actually help us to, we'll guide the family doctor and tell what is this and how you can navigate if the child requires hospitalization or requires immediate care. Reference hospital, so once this child is referred to us or to palliative care, we make sure that we are in constant touch with the doctors that referred us from the hospital. So we are in constant touch with GMC or with district hospitals or with the community health centers, whichever doctor is referring us. So we are in a connection with them. So we don't lose it. Once you refer to us, it doesn't become our child. It's our child. So we look together. So we help the child together with the treating doctor and us. Local hospitals, so for example, I said if the child requires immediate care, then we see that we can transfer the child to a community health center or a primary health center instead of the child coming directly to GMC. Say, for example, we have a child in extreme Pedne that is starting borders of Maharashtra, even beyond Mopa. Now I have traveled, so personally I know the distance from GMC to that. It takes me approximately 3 hours to go. Now imagine in emergency coming from 3 hours here. So families in distress will soon come like that, running, they want to come. But ultimately the small things can be done in a PHC, which they don't know. So that kind of awareness is what we try to do for them. Social services. So one of the things that we do is, have you all heard of UDID cards? What is UDID? Yes, correct. So in order to get your UDID, what do you need to do? Oh, before all that, what you need to do? No, you don't need. Okay, again I'll correct. No. Okay, DSM they don't use in India. They use ICD category. Okay, fine. Okay, you told me the whole process. Okay, now I'll make a small change in your process. So the change in the process is like this. In order to get a UDID card, you have to get your disability assessed. Now, how this assessment takes place, have you all ever tried to find out? No, Setu is not considered. Setu does not. No, Setu is because of their assessment. But when it comes to government ID, okay, IPHB is one of them. So, and South, correct. So in order to get your disability assessed, you need to have your IQ done. You need to have whichever doctor is treating has to tell you whether you're multiply challenged. You need to get your hearing done. You need to get your vision done. And only then will you go in to get your disability certificate, then you will get the UDID card. Now this is a long process. Especially this assessment happens only when you need government agencies to certify this. So Setu cannot certify this. Setu does it for their organization, for their understanding when it comes to working with the child. Because that's what they have to do, because ultimately they have to get the knowledge how to work with the child. But when it comes to certifying, they have to go and do that. So we work in collaboration with Dr. Nandita when it comes to getting this kind of assessment done for the child, because it's a saga in GMC. Right now in IPHB, you're getting IQ assessments because of the number of patients in 2 years. So next year end, you're getting your date. If you go to DIEC, this is a reality. You go to DIEC in South Goa right now, shortage. So they are actually having the next appointment is next year June, because I'm fighting for one child. So next year June. It's a fact, yes. So the same, even in DIC North Goa, it's the same thing. We have to get the assessment done. So now they have started a new BERA, just for knowledge. They have BERA being done in Azilo and Mapsa. So you can take your appointments there. But because everybody is leaving GMC, everybody is running to DIC there. Sorry, to Azilo there. So again, that's again a long, so children take a long time to get this done, especially when they want to get their admission in special schools. So we try to make that fast because of the collaboration that we have and the contacts that we have. We try to make it faster for them. Also, we help the family in getting their child's MRI done on time, helping the family to actually get their other assessments and reviews done in hospitals. So that's our kind of social services that we do for them. Community teams. So as I said, we don't have many volunteers. We just have one volunteer at the moment. That is in Usgaon. Okay, so she goes in the nearby areas, looks if there is any child that who she feels would require palliative care or any kind of assessment. She contacts us. Then we go do the need assessment, see if the child is actually fitting our criteria. Refer, Dr. Meena sees, so Dr. Philomena sees the child, sees if the child requires palliative care. Then we start the whole process of assessment for the child. Yes, so that's the team of CPC. Now coming to what we do as counselors in palliative care. So our key elements of counseling in palliative care, for children's palliative care. So we focus on needs and hope. Now when you're working with a child who's dying, you know that the child is dying, but you don't take away the hope. That is something at all throughout your counseling sessions, that hope should, the way you frame your sentences, the way you communicate becomes very important, because it's a trigger. The minute you use a negative word, the family catches on it. And then they'll harp on it and they'll come to you 10 times. So the way you communicate, the way you frame your sentences becomes very important when you're dealing with pediatric palliative care. So we don't take away the hope. We focus on the needs. So we don't, as in the introduction they said that I handle a project in Tata's which was on decisional preferences in palliative care, meaning whether the patient is given autonomy to take the decisions or the primary health care takes the decision, or whether the family takes. Sadly, 90% of my research was that the doctors take the decision, and the rest 10% takes the family members. And later on, the parent says, I didn't know anything. Reality is the family doesn't want to take the decision, so they say, doctor will tell everything. Doctor knows the best. So decisional control preferences are not there in families because they are not given that autonomy. They feel that, they want to, fall back and say that, my family will take the decision or my doctor will take the decision. They don't want to be a part of the decision making. It is because of our cultural background, no doubt about it. But some way we can make a change in making sure that the family is a part of the decision of the child's treatment. So we make sure that there is time together as a family. So whether it is, whether we are trying to change the tube of the child or we are trying to teach the child something, we make sure that the family is there. Either the siblings are there, mothers, their grandparent, whoever is there. We make them be a part of it. Not that, we are as therapists coming there, sitting with the child or the family and going. We want everybody to be there. So they are a part of it. So time together as a family becomes very important. Second, desires and needs to be addressed. So when you are actually counseling, you will ask them, what do you need? So when our first step in the homes is, what do you expect from us? We tell them who we are and why we are here, who's referred you all to us. Ask them, what do they need from us? Then they will tell us a whole list or whatever they have to tell us. Then we ask them, what are your desires? What do you hope? What do you wish for? So they'll say, for example, recently we have been referred another case, cancer case, which is terminally ill. The child is, there is no active treatment being done. But the auntie seems to be very close to this boy. So I had to counsel this child in the hospital. Sorry, the auntie in the hospital. So I told her the prognosis. She's aware of it, but I had to tell her again because sometimes you're in denial, so you have to say it again. So told the prognosis again to the family, to the auntie. Then the auntie said, see, I know all this, but somewhere there is hope that this fellow will be the first one to challenge neuroblastoma. So that was the thing, she said he'll be the first one to challenge. And they were planning of a treatment, did not work out. So now the child has gone home on oral chemo. And when I follow up with the family over the phone, the family tells me that the child is doing well. They've accepted, they take him out. So they've understood that now they have to actually add life to the days that he has, not the days to the life that he has. So they're trying to actually bring quality life to him. So they take him out, they take him to the beach, take him for movies. So, but they are not accepting us to come for home care. So when I asked them, can I come do a home visit? They said, no, doctor, no, madam, don't come for home visit, Then the whole thing is, you all might tell me again that he won't live, but we are having this hope. So now we want to do a home visit, so we cannot push ourselves. So respecting that privacy, setting back, and only on phone follow-ups to know whether the child is doing well or not. Because they don't want us to come there and tell them that there is no hope. So we are respecting that they have hope, and we are respecting that we are going to be there. So my end statement always is always like this. Call me whenever you need, we are always there for you. So waiting for that opportunity, that when will I be able to come and see the child, so that I can also see the child and see whether he's understanding what it is. It was very important for them also to know, because he knows that something is wrong with him. So as a counselor, it becomes important for me to know that I address some needs of his. He may have so many needs, like why me as a kid? So I'm waiting for that opportunity when I will get, where they'll get comfortable with me coming to their home and seeing the child, and only then will I make a step. Allowed to hold on to their hopes. So nowhere you are going to be like, though you're irritated, you have had 3 patients before this, now this is the 4th home visit, and the 4th home visit tells you that, I have hope, but you in your head know there is no hope, but you cannot say no, there is no hope. And very important in counseling, if you cannot continue the session, break the session. You don't go on. Just because you have to complete that home visit or you have to complete that session, don't go on. Many times I've seen that, they push, they want to do it, they finish it, they tell the prognosis fast. No way of understanding, no way of even thinking that the family is, going to cry any moment, but you want to finish and go. That's not a counselor's job in palliative care. It is to understand that you have saturated and it is time to break and say, I will see you later. And you need to gauge whether the family is ready to listen to what you're saying. Sometimes they are there, but they are there somewhere. They are there present, but mentally reached another land. So just because you're talking doesn't work out in counseling. You need to be in the present in order. The family has to be present in order to understand what you're saying. So if you gauge that this is not happening, stop the session and say bye, thank you. it's very important to empower parenthood. Now, the mother who has just given birth to a child with a genetic condition, she says, what is the use? My fault only. Every time it's my fault because I'm the lady. So I've given birth. My husband says, because of me, this has happened. So then she starts to detach from the child, doesn't want to care for the child. So when that happens, you need to gauge and say that, you need to get into this picture and say, no, it's not your fault. It's nobody's fault. It's the fault of the genes, which is from the father half from the mother. So today's case only I'll tell you. Visited GMC in the morning, got a case referred to us, meaning it's an old case, but got it again referred to us because the child got admitted in GMC. They wanted to do genetic testing. Now I know the whole story of this mother, and I know that genetic testing was done some time back, and they had lost the papers. So mother calls me and says, Didi, doctor ने बोला genetic testing करने का. I said, आपने पहले किया था, आप पहले वापस क्यों 15,000 waste कर रहे हो? So she said to me, दीदी नहीं, मैंने डिवोर्स के लिए फाइल किया पति से, तो उसको पता चले कि ये मेरा फॉल्ट नहीं, आपका फॉल्ट है. So basically she doesn't mind spending another 15,000 just to do the blame game now. So because she's already detached from the child, she doesn't want to care for the child because she is now come to a stage where her husband has disowned her because of the child with this problem, and now she wants to spend another 15,000 just to prove that he was wrong. So again, the whole counseling begins again with them. So we had to put it on a hold, say there is no need right now. However, we'll get back to you after discussing. So you need to know you need to allow the family to get to know their child. So even that period where the child is sick, we make sure that the mother is present all the time so that there is some form of attachment, the child and the mother. Encourage the efforts taken by their parents in the child's treatment. Many times we have mothers ask, what less did I do? Did I miss something? I think I should have taken him to that Baba. We have families who say that, that they were referred to some Baba in Himachal Pradesh. We had to go there. We didn't go because we listened to y'all. So that kind of question comes, that we have not done enough. So reassuring them that you have done everything that you could do for this child. This is a genetic condition. There's nothing that you could have done. Okay, it's all come from up. So making them, so they're always in that bargain, like, I did something less. So we get them back to the root to make them know that, no, this is not your fault. It's nobody's fault. It's just come to you. And maybe because you're blessed to take care of this child, you've been given to this. So again, making them understand that, maybe you're unique to able to handle this child. So making them understand that this is what they need. At the end, they need to care for the child and not detach from the child. Attentive and transparent communication. As I said, you need to be very sure of the words you use. When you go in counseling, especially with pediatric palliative care, you are not going to go say there, hi, I'm come to talk about your child. Instead of that, you are going to tell who you are. You are going to always address the child by the name because that's when they feel connection. Always say that I'm come to meet Raju or I'm come to meet Ram. Address the child's name. Don't say I'm going to meet your child, I'm going to meet the patient. They don't want to hear this. They want to hear the name. And when you say the name, you will realize that it is an immediate attachment, and that's the time they start crying when you start to say their name. Second part, when the parent starts to open up, is when you just touch them. All this time, you will see that the mother is completely emotionless. She's blank in front of you. You're listening to her, but one tap and the parent starts to cry. Now, when you see a parent crying, what would you do? Yes, allow the parent to cry. Second, you're not in a position. Okay, I'll take it. So, okay, console the parent. And what? Reflect on the feelings. Yes, very good. You'll reflect on the feelings and you will ask the parent whether you want to continue it or whether should I stop. Because when the parent is crying, you've seen the parent has stopped crying, but at that point the parent might be not ready to listen to what you're going to say next. So you ask permission from the parent, do I stop or do I continue? If the parent says continue, then you continue the session. If they say stop, then you ask them, when can I come next, best to meet you, or when it would be nice for me to talk to you about your child Ram. Assess the illness understanding. So when the patient is sent for you for counseling, you as a counselor may not know all the diseases. So when you are being told about this is a child with this disease, what are you going to do? You are going to go back, research. Now Google becomes our master, but Google is also wrong. So you go back to the treating doctor and ask, what is the disease? How do you want me to tell the patient, how do you want me to tell the patient what is the disease, what is the prognosis, how do you go about? Don't rely on Google to go and do your counseling, especially when it comes to diseases. Go back to the doctor who referred you. Ask them, what is it right now? If you did not understand, don't be ashamed to ask the doctor, what is it? Can you break it down to me? Doctors will do it to you because now it's different approach now from all the doctors in the hospital. They are willing to spend some time with someone who's ready to give that kind of time to a patient who they are referring to. So they will break it down to you, they will tell you what it is, then only go and do the counseling. Don't take the reference, run for counseling. You may go and do blunders there instead of doing right. So don't rely completely on Google and don't go with half knowledge because it's dangerous. So you do with what is been told by your treating doctor. So in order to assess their illness understanding, you have to assess your understanding of the disease. So when you have understood the disease, you will be able to assess how much do they know. Once you know how much do they know, then you will tell them what you know. So you need to know how much they know. You can just not go and tell them how much you know. So first find out how much they know, then you tell how much you know, and then see what do they want next. What do you want? Do you want to go forward? Do you want to know more about your child? Do you want to know what is the next step? So if they say not right now, then you stop it. After they say, okay, I want to know more, I want to know what is the next step, then you share the prognosis, whether it's good or bad, whether the child is actually going down or the child is actually improving. So you need to share the prognosis in a way that is acceptable, not harsh. You need to be soft, you need to be compassionate. Important aspects of counseling should be there. So if you're compassionate, your touch is friendly, your touch is warm, your voice, your tone is warm, the parent is immediately going to understand what you're trying to tell and is going to be able to actually digest the fact what you're telling. Because you're giving the family, the parent, space to express. Evaluating choices and goals together. Now, when this child gets referred to us, we would want to evaluate how much further do they want to go with this child. For example, option 1, 2, 3 are given in front of them. We'll ask them, which options do you want? Do you want any of these? Don't want any of these? What next do you want? So we'll together set goals for this child. Plan of care is very important when it comes to palliative care. So as a counselor, we'll set goals. We'll say, okay, this is what you want for the child. This is kind of help that you require. We will go ahead with the goals. Fears and worries. So next we'll ask them, what is it that you're worried about? What are the fears do you have? Then the family say, after discharge, if the child bleeds, what do we do? Then we say, we are there. If the child bleeds, you give us a call, we will do a home visit, or immediate action, what is to be done, we will tell you. So that there is someone that they can, lie back on. So that kind of security we have to give them. And sources of strength. Now we make sure that there is support system around them. It's very important. They cannot fight this battle in a hospital all by themselves. So we require to have a source of strength for them. We are one, we make sure that they get the other. That is their relatives or friends or neighbors, whoever is. So we make sure that our social assessment is extremely strong. And if there is no social support, then we become the only support for them throughout the journey. Advanced care planning. So whether it is medical or non-medical issues are thoroughly evaluated and discussed regarding possible disease trajectories. So whether it is a medical problem, meaning concern or a non-medical concern, we are actually together planning the goal of care for them. So we ask them what they want from us, we note down, we show them that this is what we plan to do with the child, or this is what we plan to do on our home visits with you. If they agree, we go ahead with it. Besides supporting parents by preparing them for an emergency or crisis situation, the goal is to identify central wishes and concern and pave the way for shared decision for future interventions. So we are not going to at any cost tell them this is what we want for him and this is ultimate. If they say no, we don't want to, that we have families who have told us stop coming. We don't want more intervention. We don't want you all visiting us. We've stopped. But we also do phone follow-up. So we keep contact with the family over phone. We do not go to their homes because they don't want, because the goal of care ended there after 2-3 visits and they don't want us after that. because they are happy to help the meaning be with the child on their own. They don't want anybody coming and seeing the child every 15 days. So we make sure that we are together when it comes to planning their care. End of life care. Have you heard of this term? Have you heard of end of life care? What is end of life care? Sorry. Okay, what is end of life? Don't look at there. Remove the life support system.
Probably the counseling of the child, parents of the child after the child's death, end of life.
No.
The last segment when the child
Is
was
almost dying,
almost
yes.
dying, and how much pain relief care and quality care you can provide in that time and make the most of the family time, etc.
Correct. So it is once the final stage of dying process has begun, it is the team's primary task to stay in attendance without being intrusive. So I'll share a small experience with this. So I had this child when I first joined Tata's. She was a cancer girl, 18-year-old. She knew she was dying because we used to have narrative analysis, narrative diaries that we used to have as a part of a project which I was not a part of, but I used to just help them with it. So this girl used to write her diary every day during her whole protocol, what she was going through, what she used to do when she used to come to the OPD or go to the ward. So everything she had written down. So now she came, the final stages of her death have come, and they have to give this diary back to us. So the mother came with the diary to us and gave it to us. And she said, Madam, my daughter has taken sannyas. She has gone to a place far away from us, in a place that, she was a Jain, so she's gone far away, where she didn't want to be in contact with us. She wants to go there and die peacefully. She doesn't want to be a part of our family at this moment, and we have respected this. We've let her go. And she also told us that before she was leaving, she has made like a mini will, saying that my clothes will go to this sister, my shoes will go to this sister, my laptop will go to my brother. She had it all written down in her diary, making sure that whatever belonged to and was dear to her went to the ones that loved her the most. So she let go, and also she wrote in her diary at the end, I'm leaving, and I'm leaving this world because I came alone and I'm going back alone. I don't want to give my family pain when I'm dying. So she went back to die on her own. Because she written in her language, she wrote, we had to translate it in English, I'm come alone, I will go alone. And therefore I've taken this decision. So she left this place. I left her belongings to the people that she loved the most. So a child does understand, meaning she's 18 years old, no doubt. But I'm sure we would not do something like that. We would want our loved ones near us. But she understood this so well that she wanted to go away because she did not want, she said there that I've seen my mother cry days and nights, hoping that I will get cured. But she said that I have no cure and I'm going away. So the final stages of dying, when it began, this is what happened with her, and this is how she ended. The goal is to enable the child to die in comfort and with dignity. Now I'll share another experience with this. So recently we had a kid who died, okay? And the kid is an outsider. And unfortunately, the family could not arrange for last rituals. They did not have finances. And so our team was in hospital, and the team went to see it because they knew the child was admitted, so they went to see whether the child is doing well. So there they came to know the child died the previous night. And now this family has no money, nothing. They are migrants. As you know, a lot of migrants in Goa come because of the treatment available at Goa Medical College. So this family, she went in search of this family, my team members, the two of them. They went in search of this family. They found the family outside the hospital, standing with a box. So they said, where is the baby? We came to know, mar gaya. Didi, box mein hai bacha. So the dead child was in a box because they did not have finances to do a proper, to take the child home. They were taking the child to bury in a box. by bus, because they did not know how to arrange for hearse van or how to arrange for services. Now our team was so spontaneous and so proactive that they went to the municipality, got his admission for the burial, made sure that he was there when they were buried. They arranged for a van in GMC who was willing to take this baby in the van for burial. So we need to make sure that the child dies in dignity. And the rituals are done, because that's the last thing that the family has, is the rituals. You don't want that to go away from them. You don't want them to be left empty. So making sure that the child is laid down peacefully and the family gets the time required with the child. Parents should be braced for understanding and anticipating possible symptoms, reflexes, and behavior patterns of dying child in order to avoid confusion and fear. Can you tell me of some kind of anticipated problems that you would see in a cancer child? For example, cancer is a common disease now. No, you know that to anticipate symptoms of dying. Sudden pain and breathlessness, yes. Okay. So when you see that the child is going breathless, or the child is, now slowly closing his eyes, you have to tell the family that this is what you can expect. Or you can expect a sudden drop in intake of food, or the child becomes drowsy. So you need to prepare them for the final stages of dying. Grief and bereavement counseling becomes very important, because grief begins when the child is diagnosed and goes on for as long as the family remembers the child, or even, I don't know, after how many years is a trigger, maybe a memory, and then again the process of grief. So grieving is a process, it does not end, it goes on. You will remember, sometimes you remember our grandparents and think, oh, cry about them. Or if you've lost our loved ones, we think of them after so many years. For example, I have heard stories of my grandfather when I was a kid. And now I think of it and I said, oh, I wish he was there. And then, suddenly you become sad and you want to be away from everyone. That's the process of grieving. It's a process, it won't end. And don't expect to tell the family it's okay. You will be okay. You will never be okay. But the thing is, you need to cope with being okay. You need to cope with the whole process. You need to cope and you need to accept that process, that this is a part of me and this cannot go. So this cannot happen in one go. It is a long time, long process, long counseling, understanding of the process of grieving. Grief is a normal reaction to loss. Supportive grief counseling fosters the parent-child relationship as well as the bonding process with the entire family. So if your grieving process is proper, when I say proper, it's in a conducive manner, or it's in a manner that is supportive, you will see that the family is also, falling back on other relatives. Many times we have that families are just two of them are together. They don't want the extended family being a part of it, and then there's blame game. So it's supposed to be actually a way of bonding, and how does this happen is only when a counselor gets in and makes them understand this is a process, and we all have to sit together and grieve about it or talk about it, and only then will you be able to come out of it at that point. Grief counseling carefully seeks out paths and taps resources for a healthy continuation of an emotionally, psychologically, socially, spiritually, and a physically stable life. So if you are unable to tap onto this at the right time, you will see that the family is not able to come back to life. Is not going to live their life again. They will be stuck there. We had a child that was referred to us in 2018, died sudden, okay? Blame everybody because also there was no understanding of the disease. The mother is still locked in her room, not accepting us, not accepting her relatives. So how do we get into it? We are still fighting our way to get in, to make her understand that it was not her fault, it was nobody's fault, it was just sudden death. The long-term goal of grief counseling is to enable grieving families to integrate the loss of a child into their lives. So if you see in Western cultures, you'll see that they make a garden, they plant flowers and they call it the garden of their child. Something that we can also do with our families in Goa. Okay, like keep the favorite toy with you, don't burn. Like there are a lot of rituals in Hinduism that they burn the toys. So this child that we had who died, who was in the box I told you, there was a potli behind the father's back, and my team was sharing with me, and she said, I wondered what that potli was. I thought first the child was in the potli. Then she said no, then they said the child is in the box. All his toys and clothes were there. They didn't want any of his memories with them. So, but the counselor on team made them understand that at least one toy you keep with you, and then he will tell you why. Then after that, we get a call saying that they felt good having that toy with them at night, especially the mother. Felt comfortable knowing that there was a toy of a child with her. As per the ritual, they had to bury everything of the child with the child. At the beginning of their bereavement journey, parents need to be need a proactive, accessible contact. So once the child dies, you cannot say bye to the family, or you cannot say, hey, I don't need to pick up her call, or I don't need to pick up his call. You have to pick up, because they are relying on you for that support at that moment, just to console them. If we did not get that console, or do not get that feeling of being loved by or supported by someone, they are going to go back in their nutshell. So you have to be available for them. Spirituality and religion. So many times they are having this conflict between religiosity and spirituality. So when the child is diagnosed, they question their existentialism. Why did this happen to me? Why to me? Why am I that mother? Why am I that father? Why should I have this child? How am I going to take care of this child? God thought of what this child is going to be born to me because I'm a strong mother. All those questions are asked to us. Because for them it is, oh, the baby is born and we have now a plan for the child. Suddenly that plan gets destroyed. So question of spirituality, religion, why this, why me, why to my child, all come into play. Assumptions about life, its meaning, its value, and its spiritual, religious grounding are suddenly called into question. So all I used to put, during my pregnancy, I went every day to the temple, I went every day to the church, I went every day, did my namaz, but why me? All these questions come. I've done everything when it comes to my religion and praying to God, but why me? Then the next question, everything was good during my pregnancy. Why did this happen last minute? Doctor did not tell me anything that was wrong during my pregnancy. Otherwise, I would have terminated. These are the questions that they ask. Why only now? But you need, as a counselor, need to make them understand that this can happen even after birth. And some abnormalities cannot be detected during birth, during the process of carrying the child. People inquire into the mystery of life and seek its meaning. So they reach a different level altogether. Bringing them back to here and now becomes very difficult for us. And it's a process. It doesn't end. We get them back to the present, making them understand the meaning of their life and why they had to go through this. And you're not alone. So when we say we are not alone, we address them through support groups. So in palliative care, am I running late? Very late? Okay. So last is support groups. So it's very important for us to have support group meetings for these families so that they can address their problems and that they feel that they are not alone in this journey. Okay, I'll go fast. Okay. In order to provide palliative care, you need to first take care of yourself. So team care is extremely important, your own care, in order to provide that care. So this, you know, our core values are compassion, honesty, respect, accountability, and teamwork to provide quality of life so that we are adding life to days and not days to life. So I'll just say something about Novi Survat. So Novi Survat Goa has 2 units. One is a physiotherapy unit and one is a home-based children's palliative care unit, which I am a part of. And the physiotherapy unit is my colleague Ghislaine, who is a recreational therapist for that unit. Now, Novi Survat Goa's primary goal is home-based palliative care. So this is what we do, and these are our components. We make sure that the family is available, is accepting us. We make sure that there's a caregiver. We make sure there is no stigma attached. We make sure that we are trained. We don't send anybody on board. 24-hour support. Transportation is provided for the home care team. Network of supportive care, and we have a home care kit which is with all the emergency medicines that are required on the visit. So our aim is living as well as possible for as long as possible. Let us not wait till it is the end. So you can be the change at any time. If you want to see change, you need to be the change. Don't expect things to change one day and then you will be a part of that change. You need to start being a revolutionist. Thank you.